Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing a very important topic in the hepatology, that is primary sclerosing cholangitis. So what exactly is the problem in this primary sclerosing cholangitis is the word primary means you don't have the pathology somewhere else. The problem is within the organ. That is what is called primary. Okay. So it is not caused by something else. What do you understand by this word sclerosing? The word sclerosing means it is the hardening of the tissue is what is called as sclerosing. Cholangitis, the word cholan, it is nothing but your bile duct. Itis, it is nothing but the inflammation. So basically, it is the inflammation of the bile duct and as well as the hardening of the tissue. That is what is nothing but your primary sclerosing cholangitis. Now, what exactly is the reason for the development of this sclerosis or the hardening of the tissue? And what is the mechanism or what is the reason for the inflammation of the bile duct? Let me say you that. So, this primary sclerosing cholangitis, this is one of the rare clinical entity, right? So, this is not a common condition. It is an uncommon disease. And this primary sclerosing cholangitis, it is thought to result from an increased immune response to the intestinal endotoxins. Okay, so there will be a release of the intestinal endotoxins, right? There will be release of the intestinal endotoxins. Now, in response to this intestinal endotoxins, there is an increased immune response. Right? And this increased immune response is what is responsible for the development of primary sclerosing cholangitis. And this increased immune response, this is characterized by diffuse inflammation of the biliary tract, right? Diffuse inflammation of the biliary tract. And this diffuse inflammation of the biliary tract, this leads to fibrosis and strictures of the biliary system. Right, strictures of the biliary system. Okay, so this is what is your primary sclerosing cholangitis, where there is diffuse inflammation within the biliary tract, and that inflammation will lead to the fibrosis and as well as the strictures in the entire biliary system. And you need to be aware of what is the age group, right? So if you take the points related to primary sclerosing cholangitis, you need to be aware of what is the age group at which you see this primary sclerosing cholangitis. In almost 60 to 70% of the affected persons, they are males, right? So it is predominantly observed in males rather than females. And what is the age group the clinical presentation will be usually with? The clinical presentation will be usually around the age of 20 to 50 years of age. And this primary sclerosing cholangitis, it is associated with the other disorders. What is that other disorder which is having close association with the primary sclerosing cholangitis is the primary sclerosing cholangitis, it is closely associated with inflammatory bowel disease. right? It is closely associated with inflammatory bowel disease. Now, among these inflammatory bowel disease, like we have the two forms of the inflammatory bowel disease. One is like Crohn's disease, the other one is ulcerative colitis. And this is more commonly associated with ulcerative colitis than the Crohn's disease, right? Most commonly associated with ulcerative colitis than the Crohn's colitis. And some other disorders also you are associated with this primary sclerosing cholangitis. What are the other disorders? The other disorders which are having the association is, it is associated with cardiovascular disease, and it is also associated with diabetes mellitus, right? Now you need to be aware of like why is it having the association with diabetes mellitus? Why? Because if you take the HLA association, right? If you observe the HLA association of the primary sclerosing cholangitis is associated with the following HLA. That is HLA B8 and the HLA DR3 or DR4. Now, even if you take diabetes mellitus, it is type 1 diabetes mellitus is common in individuals who are having the HLA DR3 and as well as DR4 association. So, even your primary sclerosing cholangitis is also common in individuals with HLA DR3 and DR4. So, that is the reason why both of them are having DR3, DR4 association. So, that is the reason why your primary sclerosing cholangitis is associated with the diabetes mellitus. And what about the family history? So, if you take the family history, the first degree relatives, right, the first degree relatives of primary sclerosing cholangitis, they are having, right, almost 4-folds increase in the risk of primary sclerosing cholangitis. Right, first degree relatives, they are having almost 4-folds increase in the risk of primary sclerosing cholangitis. Almost 4-folds increase in the risk of primary sclerosing cholangitis, the first degree relatives. Okay, and there are certain factors which decreases the risk of primary sclerosing cholangitis. So what are the factors? Right? What are the factors that decrease the risk of primary sclerosing cholangitis? The factors which will decrease the risk of primary sclerosing cholangitis are, number 1, smoking, right? Number 2, statins. Statins, this atorvastatin, rosuvastatin and pitavastatin, they have a pleiotropic effect. And they are the one, this pleiotropic effect of the statins, that is the one which will decrease the risk of primary sclerosing cholangitis. And next is the consumption of the coffee. Right, consumption of the coffee. So these are the factors which will decrease the risk of the primary sclerosing cholangitis. Now, you need to be aware of what are the clinical features. Right? What are the clinical features in patients with the primary sclerosing cholangitis? So, if you observe the clinical features, right? If you observe the clinical features, majority of these patients with primary sclerosing cholangitis, they are asymptomatic. And when do they actually develop the symptoms? See, they develop the symptoms when the biliary tract is sclerosed very hardly. So in the sense, if the sclerosis of the biliary tract is so severe, where the biliary tract is like completely narrowed and closed, That is the point when the clinical features of primary sclerosing cholangitis is observed. So most of these patients, they are asymptomatic. And if at all, if they are symptomatic, what will be the earliest symptom? Right? So the earliest, right? The earliest and as well as the commonest symptom will be pruritus. That is the earliest manifestation, and you need to know why there is like pruritus. So initially this pruritus also, it is just localized, right? It is just localized to palms and as well as sole. But as the time progresses, this pruritus, it becomes generalized. Right? As the time progresses, the pruritus, it becomes generalized. So that is about the pruritus. What exactly is the reason for pruritus? The reason or the mechanism for the pruritus is, in patients with the primary sclerosing cholangitis, the bilirubin, bile acids and bile salts, they don't enter into the second part of the duodenum, which usually has to occur. The entire bile should flow into the second part of the duodenum through the common bile duct. But here what is happening? There is intrahepatic and extrahepatic sclerosis of the biliary tree, and there is complete narrowing. So the bile salts, bile acids, bilirubin, they will not enter into the second part of the duodenum. Instead, they enter into the systemic circulation through the hepatic veins. And once they enter into the systemic circulation, these bile salts and bile acids, they come and deposit within the skin. And that will be responsible for the development of the pruritus. So pruritus, it is the earliest and as well as the commonest manifestation. Right? And because there will be excess amount of bilirubin which will be entering into the systemic circulation, this bilirubin will go and accumulate within the sclera, where the patient will have the presentation of the jaundice. And another very, very important feature is melanosis. Now, what is this melanosis? Melanosis is gradual darkening of right? So there is gradual darkening of the exposed areas of the skin. Right? Gradual darkening of the exposed areas of the skin. And that is what is nothing but the melanosis. Why is this melanosis happening? Why there is gradual darkening? Again, it is the same reason, because of the accumulation of bile salts and as well as bile acids. And there is like continuous itching also, and that will contribute to the melanosis. Alright? And these patients, they also have deficiency of your fat-soluble vitamins, because your bile salts, bile acids, they are not entering into your second part of the duodenum. So the digestion of the fats, right, does not occur. Metabolism of the fats does not occur. So absorption of the fat-soluble vitamins does not occur. So there is deficiency of the fat-soluble vitamins. Right? And what are these fat-soluble vitamins? A, D, E, K. These are the fat-soluble vitamins. Now, the point is, due to deficiency of vitamin D, these patients, they will have the hypocalcemia, because vitamin D is required for the calcium absorption across the intestine. So now once there is vitamin D deficiency, that will result in the hypocalcemia. And this hypocalcemia is the one which will contribute to the bone pain, because there is like osteoporosis. There will be decrease in the bone mineral density because of the hypocalcemia, and that will result in the bone pain. And next is, there is deficiency of vitamin K, and that will contribute to excessive bleeding. because vitamin K is the one which is required for the synthesis of the coagulation factors like 2, 7, 9, 10. And when there is vitamin K deficiency, you don't have the synthesis of coagulation factors, and that will contribute to increased bleeding tendency. So when you examine the patient, you will have the bruises, right? So there is bruising over the skin. That is due to vitamin K deficiency. And the next important is vitamin A deficiency. Okay. So because of this vitamin A deficiency, the presentation of the patient will be in the form of night blindness. Right, the presentation of the patient will be in the form of night blindness. So that is due to vitamin A deficiency. And in these individuals, what is that we have discussed? The fat is not metabolized. So when the fat is not metabolized, this fat, it will go and accumulate within the skin, and that is represented in the form of what is called as xanthomas or xanthelasmas. Okay, so these patients, on examination of the skin, they will have xanthomas or xanthelasma. Okay, and why is that? That is because of increase in the levels of the serum lipids. Right, that is because of increase in the levels of the serum lipids. So this will be the clinical features in patients with the primary sclerosing cholangitis. But before the development of these symptoms itself, what is the one important marker which is suspicious that the individual might be having this primary sclerosing cholangitis is elevation of the alkaline phosphatase levels. So right, so how will you do a pre-symptomatic phase diagnosis? So if you take the pre-symptomatic phase diagnosis, it is done by estimation of elevated alkaline phosphatase. See, alkaline phosphatase, it is the marker of the liver injury, right? So how is that you will do the pre-symptomatic phase diagnosis? That is by elevated alkaline phosphatase levels. That is about the pre-symptomatic diagnosis. But how will you diagnose? What exactly is the investigation of the choice? So if you take the diagnosis in patients with primary sclerosing cholangitis, the investigation of choice in these patients is MRCP. That is magnetic resonance cholangiopancreatography. That is the investigation of choice. Now, if you take the sensitivity of your MRCP, the sensitivity of MRCP will be equivalent to that of the ERCP. Right? The sensitivity of the MRCP will be equivalent to that of the ERCP. Okay? What is this ERCP? That is enteroretrograde cholangiopancreatography. But what is that we do preferably is we do MRCP rather than ERCP. Now, what is the reason or what is the mechanism? Because the ERCP, it is an invasive procedure. Right? ERCP is an invasive procedure. So that is the reason why the preferable investigation that we do is MRCP, magnetic resonance cholangiopancreatography. Now, when you do MRCP or ERCP, what is that you will observe in MRCP or ERCP? You will notice that there is segmental fibrosis of the bile duct. Right? So you will be able to visualize this fibrosis of both the intrahepatic and as well as the extrahepatic bile duct. That can be made out in the MRCP. So in MRCP, you will notice that there is right, there is segmental fibrosis of the bile duct, right? And along with the fibrosis of the bile duct, there is also saccular dilatation between the strictures. Right, there will be saccular dilatations between the strictures. Okay, so that is what you will observe in the MRCP. And not only that, the MRCP will also helps in visualization of if there is any presence of the stone or tumor within the biliary tree. Right, so that is about the workup or the investigation. Now, is there any requirement of the liver biopsy? Please remember, liver biopsy as such, it is not necessary. Right, liver biopsy, it is not necessary in patients with the primary sclerosing cholangitis. Now, what is the indication for liver biopsy? Because MRCP itself is giving you the diagnosis. Then what is the purpose of doing liver biopsy? It is not required. But what has been observed that in 15% of patients, right, in 15% of patients, the sclerosis is just confined only to the small intrahepatic bile ducts. Okay, so the disease, it is confined to small right, the disease is confined to small intrahepatic bile ducts. Now, when the disease is confined to the small intrahepatic bile ducts, in this scenario, your MRCP will not be able to pick up that sclerosis. The MRCP can be normal. Right, the MRCP can be normal. Right, now in this case, where your MRCP is normal, but you are suspecting primary sclerosing cholangitis, in these cases, you need to plan for the biopsy. Right, in these cases, you need to plan for the liver biopsy. Now, when you do a liver biopsy, what is that you will observe in the liver biopsy? But before that, let me tell you how will be the survival of the individual. If suppose, if there is involvement of both large and as well as small bile ducts, right, if there is involvement of both large and as well as small bile ducts, then the prognosis will be bad then compared to that of the involvement of only small intrahepatic bile duct. So if there is involvement of only, right, if there is involvement of only small intrahepatic bile ducts, then the outcome is said to be good. Right, the outcome is said to be good if there is involvement of only intrahepatic bile ducts. Understood? And when there is only intrahepatic bile duct involvement, what did I tell you? MRCP may be normal. In such case, you need to do liver biopsy. Right? When you do a liver biopsy, what does the liver biopsy shows? The liver biopsy will show you that there is a periductal fibrosis. So when you just see surrounding the duct, you will notice that there is a periductal fibrosis. And this periductal fibrosis, how is it observed or how is it visualized under the microscopy? That is in the form of the onion skinning. Right, that is in the form of the onion skinning. So surrounding the duct, you will notice that the fibrous tissue is like accumulated in the form of whorls of the onion, and that is what is nothing but your onion skinning appearance. And by this liver biopsy, it also helps you in doing the staging. Right, so the liver biopsy allows even the staging as well. Right, now the point that you need to understand here is when there is accumulation of the fibrous tissue or the sclerosis, what is happening? There will be liver stiffness. Right? There will be liver stiffness. Now, how can you test for this liver stiffness? The liver stiffness is measured by elastography. Right? The liver stiffness is measured by the elastography. Right? Now, when you do a liver function test, what does the liver function test show? Liver function test will show you that there is elevated GGT. Okay, so you do this GGT, that is gamma glutamyl transaminase levels. So GGT levels, they are elevated, which is a marker of the liver obstruction. And the alkaline phosphatase levels, right, alkaline phosphatase levels, they are also increased. And this increased alkaline phosphatase, that is also a marker of the liver injury. And then what will happen to the bile acids? Right, the bile acids, they are also increased. Okay, because your bile acids, they are not getting emptied into the second part of the duodenum. Right, instead they enter into the systemic circulation, so there will be increase in the levels of the bile acids. Now these patients with the primary sclerosing cholangitis, they have some complications which can be observed. What are these complications that can be seen in patients with the primary sclerosing cholangitis? These patients, they are at increased risk of development of a malignancy, and that is nothing but cholangiocarcinoma, right? And this cholangiocarcinoma, when it develops, it will complicate the clinical course of the primary sclerosing cholangitis. Okay, so right, cholangiocarcinoma. So this is the tumor or the malignancy that is observed in patients with the primary sclerosing cholangitis. And you need to know that if there is development of cholangiocarcinoma in a patient with the primary sclerosing cholangitis, this tumor will complicate the course, right? It will complicate the clinical course of primary sclerosing cholangitis. Now, what is the tumor marker which shows that there might be the development of cholangiocarcinoma? You need to estimate the levels of serum CA19-9. Right? You need to estimate the levels of serum CA19-9. So this CA19-9 levels, if they are increased more than 100 units per ml, right? If they are increased more than 100 units per ml, that is suggestive of, right? It is not diagnostic of, it is suggestive of the development of this cholangiocarcinoma, right? And the next important is, how can you confirm that the patient has developed this cholangiocarcinoma? That is by doing the annual MRI with MRCP. So you need to do this MRI with MRCP every year in patients with primary sclerosing cholangitis. Now, why is that we are doing this annual MRI is for the early detection? Because the MRCP, it is highly sensitive then compared to that of ultrasonography. So in order to have the early detection of the cholangiocarcinoma, you need to do the annual MRI with MRCP, right? And the other ways by which you can make out there might be the development of cholangiocarcinoma is you need to do a PET scan, right? That is positron emission tomography. Or another important investigation is per oral cholangioscopy. So this PET and as well as peroral cholangioscopy, they have an important role in the early detection of the cholangiocarcinoma. Right, in early detection of the cholangiocarcinoma. So this is about one important anticipated complication in patients with the primary sclerosing cholangitis. Then what are the other complications? Right, so what are the other anticipated complications? The other anticipated complications apart from cholangiocarcinoma is the formation of the gallstones. Right, formation of the gallstones. See, what happens is because of the sclerosis or the fibrosis of the biliary tree, there will be like stasis of the bile. Once there is stasis of the bile, there will be formation of the gallstones there. That is an anticipated complication. And the next important is development of the cholecystitis. So you have the gallstones, and that can create, that will induce the inflammation of the gallbladder, resulting in the cholecystitis. And the another important complication is the formation of the gallbladder polyps, right? And as the time progresses, because of the continuous irritation to this gallbladder, either by the inflammation or by the gallstones, the gallbladder can go into a state of development of the gallbladder carcinoma finally. Okay, so these are the other complications that you observe in patients with the primary sclerosing cholangitis. Now, how do you treat these patients? So in the treatment, what you need to understand is, we have discussed that there is like stasis of the bile, right? And the bile which has undergone stasis can get infected by the superadded bacterial infection. So once there is a superadded bacterial infection, the individual can develop acute bacterial cholangitis, right? So in the treatment, please remember, if the patient develops the acute bacterial cholangitis, that is treated with ciprofloxacin. And what should be the dosage of the ciprofloxacin? You need to give 750 milligrams of ciprofloxacin, and that has to be given twice daily. And the route of administration is either oral or the intravenous route of administration, right? And next important is, you need to ensure that there should be improvement in the liver biochemical function, and there should be decrease in the pruritus. For that, what we give is the 𝗓𝐸𝐴𝐴 acid. Right, we give the 𝗓𝐸𝐴𝐴 acid. This 𝗓𝐸𝐴𝐴 acid, the standard dose is around 10 to 15 milligrams per kg body weight. And the route of administration of this 𝗓𝐸𝐴𝐴 acid is the oral route of administration. And what is the advantage of this 𝗓𝐸𝐴𝐴 acid? This is the one which will cause improvement in liver biochemical function, right? There will be improvement in the LFT, and then the pruritus is also reduced. So that is the advantage of giving this 𝗓𝐸𝐴𝐴 acid. And what has been found is, once you stop this 𝗓𝐸𝐴𝐴 acid, right? Once you withdraw this 𝗓𝐸𝐴𝐴 acid, it has been found to have increased the pruritus. Pruritus again will revert back when there is stoppage of this 𝗓𝐸𝐴𝐴 acid. And another important part of the treatment is the balloon dilatation. So you need to do an intervention, and this intervention is balloon dilatation. Now what is that we do the balloon dilatation? This intervention is, you need to do a careful endoscopic evaluation. You need to pass the scope along the entire biliary tree, properly study the entire biliary tree, and just try to make out where are the strictures which are very dominant. So after careful endoscopic evaluation of the biliary tree, you need to do right after careful evaluation of the biliary tree, you need to do the balloon dilatation of this localized strictures. Right, balloon dilatation of the localized strictures. And you need, if there is any dominant stricture with significant fibrosis, what is that you need to do is repeated dilatation. Right, repeated dilatation of repeated dilatation of the dominant strictures has to be done, and that will improve the survival of the individual. Okay, so that is about your balloon dilatation. And after doing this balloon dilatation, what is that you need to do is, you need to place a stent, and the stent that you place, it should be like short-term placement of the stent. So now what do you understand by this short-term placement of the stent? You need to place a stent for just only 2 to 3 weeks. Now, once you place a stent for only 2 to 3 weeks, that can improve the liver biochemical functions, and there will be also decrease in the symptoms. Right? So short-term stent placement is important. Right? Short-term placement of the stent. Whereas, what will be the disadvantage when you place the stent for longer duration? Right? So, long-term stent placement, that can increase the complications such as cholangitis. Okay? So there will be increased risk of there can be increased risk of the cholangitis whenever you place the stent for long term. So that is the reason why you should never place the stent for longer duration. Okay, so this will be right. So this will be the complication of long-term placement of the stent. Now, what is the indication for cholecystectomy? So the indication of the cholecystectomy in case of primary sclerosing cholangitis is when there is development of a gallbladder polyp, right? When there is development of a gallbladder polyp, and that too, the size of the gallbladder polyp, if it is more than 8 mm in a patient with primary sclerosing cholangitis, then you need to do cholecystectomy. So what is that we have discussed? The complications, there can be like cholangiocarcinoma, there can be gallstones, there can be gallbladder polyp, there can be gallbladder carcinoma. So when there is a development of gallbladder polyp of more than 8 mm, then you need to do cholecystectomy. Now, is there any requirement of liver transplantation in these patients? Yes. So you need to know what is the indication, right? What is the indication for the liver transplantation? So if you observe the indication of the liver transplantation, if a patient with cirrhosis, right, if the patient has developed cirrhosis because of primary sclerosing cholangitis, if the patient has developed cirrhosis because of primary sclerosing cholangitis, and along with cirrhosis, if there is clinical decompensation, right, along with cirrhosis, if there is clinical decompensation, that is the point when like liver transplantation is considered as the treatment of choice. Okay, so this is about your primary sclerosing cholangitis. So let me just quickly recap the topic of the primary sclerosing cholangitis. So primary sclerosing cholangitis is the clinical condition which is characterized by the sclerosis or the fibrosis of the intrahepatic and as well as the extrahepatic bile duct, and it is one of the rare clinical entity, and it is found to be due to increased immune response to the intestinal endotoxins, and that is characterized by the inflammation of the biliary tract leading to strictures and as well as fibrosis of the biliary system. And the age group at which you see this primary sclerosing cholangitis, it is around 20 to 50 years of age, and it is more commonly observed in males rather than females. The associated disorders are the inflammatory bowel disease, cardiovascular disease, and diabetes mellitus. And the risk factors which will reduce the primary sclerosing cholangitis is smoking, statins, and as well as consumption of coffee. And HLA association is HLA-B8, DR3, and as well as DR4. And first degree relatives of these patients with primary sclerosing cholangitis, they have almost fourfold increased risk of this primary sclerosing cholangitis. And most of these patients, they are asymptomatic, and whenever they develop the symptoms, the earliest and commonest manifestation is the pruritus. Okay, and this pruritus is initially localized and later it becomes generalized, and there will be also jaundice and as well as melanosis. And due to deficiency of your fat soluble vitamins, vitamin A deficiency will cause night blindness, vitamin K deficiency will cause bleeding and as well as bruising, and vitamin D deficiency will cause the hypocalcemia. And these patients, they will also develop xanthomas and as well as xanthelasmas. And pre-symptomatic phase diagnosis can be done by elevated levels of the alkaline phosphatase levels. And the investigation of choice is the MRCP because it is non-invasive. And what is this MRCP shows? There will be like segmental fibrosis of the bile ducts with saccular dilatation between the strictures. And usually the liver biopsy is not required, but in 15% of individuals, the strictures are just confined only to a small intrahepatic bile ducts. And when the strictures are just confined to only small intrahepatic bile ducts, then your MRCP will not be able to pick up this primary sclerosing cholangitis. In such cases, you need to do liver biopsy. And when you do a liver biopsy, you will find that there is a periductal fibrosis, and that is nothing but your onion skinning. And liver function test will show you that GGT levels are elevated, alkaline phosphatase levels are elevated, and bile acids are also increased. And the complications will be the development of the cholangiocarcinoma. And in this cholangiocarcinoma, how can you suspect that there will be, how can you suspect is the levels of CA19-9 levels are elevated more than 100 units per liter. And how can you do an early detection of the cholangiocarcinoma is you need to do an annual MRI with MRCP. And next is the PET with per oral cholangioscopy that will also have the early detection of the cholangiocarcinoma. And the other complications are the gallstones, cholecystitis, gallbladder polyps, and as well as the gallbladder carcinoma. And the treatment is when the individual develops acute bacterial cholangitis, that has to be treated with ciprofloxacin. And next important is you need to give ursodeoxycholic acid to improve the liver functions and as well as reduce the symptomatology of the individual. And the interventions which are planned is the balloon dilatation, where you will do a repeated dilatation of the dominant strictures. And short-term balloon dilatation is indicated, or it is advised, that is 2 to 3 weeks of the placement of the stent, and that will improve the biochemical functions and that will reduce the pruritus as well. But when you place the stent for a longer duration of time, and that will increase the complications such as the cholangitis. And when there is a gallbladder polyp of more than 8 mm in patients with primary sclerosing cholangitis, that will result in the cholecystectomy. And liver transplantation has to be done when there is development of cirrhosis with clinical decompensation. So this completes the discussion of this very important topic, that is primary sclerosing cholangitis. Thank you very much.